Welcome back to part 11 of our Interventional Radiology Coding Masterclass. Today, we are heading straight into the vessels. Navigating the vascular system, it can honestly feel a bit like driving through a massive, sprawling highway system without a GPS. But don't worry, today we're mapping it all out. We're going to master the 4 golden rules of vascular catheter placement coding. By the time we wrap up this explainer, you'll be navigating these vessels with absolute confidence. So let's jump right in.
Here's our roadmap for today. We'll kick things off with a quick intro to IR and catheterization, map out the vascular families, and then dive right into the core of it all, selectivity and the final placement rules. We'll wrap it up with a practical coder tip and a quick summary.
Section 1. Welcome to Part 11.
All right, setting a solid foundation is absolutely everything in medical coding. So before we get tangled up talking about branch orders and catheter tips, we really need to make sure we're perfectly aligned on the environment we're working in. Let's formally define interventional radiology, or IR. Basically, this is a medical specialty that relies heavily on real-time imaging techniques. We're talking X-ray fluoroscopy, ultrasound, CT, and MRI. Physicians use these imaging tools to perform minimally invasive diagnostic and therapeutic procedures. Now, here's a crucial rule of thumb for us as coders. All interventional radiology procedures are a part of surgery, but all surgical procedures are not a part of interventional radiology. When you're flipping through your CPT manual, yes, you're in the surgery section, but you're hunting for very specific, image-guided, minimally invasive techniques.
Section 2. Intro to IR and catheterization.
To really appreciate that distinction we just talked about, let's contrast the IR environment with a traditional surgical setting. How do we actually tell them apart? Well, same-day surgery involves your traditional operations, usually under anesthesia in a standard surgical suite. These use open approaches, large incisions or endoscopic portals. Interventional radiology, on the other hand, entirely different ballgame. It relies heavily on percutaneous approaches, and percutaneous simply means through the skin. The physician uses specialized needles and thin tubes, which we call catheters, combined with that real-time imaging to access internal structures without making large cuts. It's fantastic because it means a faster recovery and reduced risks for the patient.
Now, within interventional radiology, we encounter a major fork in the road, and as a coder, you absolutely have to know which path your physician took. We classify these procedures into 2 buckets, vascular and non-vascular IR. Vascular IR includes treatments that directly involve the blood vessels. This is where your angiograms, your angioplasties, and your stenting procedures live. The primary goal here is usually to restore or improve blood circulation. On the flip side, non-vascular IR focuses on organs or tissues completely outside the vascular system. This is the bucket for coding your fine needle aspirations, biopsies, and abscess drainages.
Let's actually test that logic right now with a real-world clinical scenario. Say the physician performs a catheterization injection procedure for an antegrade nephrostogram, complete with imaging guidance. What type of procedure is this? Is it vascular, non-vascular, both, or neither? Well, think about the anatomy for a second. A nephrostogram evaluates the kidney and the ureters. Are those blood vessels? No, definitely not. They're organs and drainage tubes outside the bloodstream. So the correct answer is option 2, non-vascular IR. Recognizing this right off the bat instantly points you to the correct section of your coding manual. It's a huge time saver.
Section 3. Vascular families.
Okay, now that we've separated the vascular from the non-vascular, let's establish the anatomical foundation you need for accurate coding. To code accurately, you really have to visualize the vascular system for what it actually is, a massive, incredibly complex branching tree. In interventional radiology, we categorize this whole network into 3 main families. First, you've got the arterial family, which includes all the vessels branching off the aorta to deliver blood. Second, the venous family, representing structures like the inferior vena cava that manage all the blood returning to the heart. And third, the lymphatic family, which includes pathways like the thoracic duct for the body's immune and fluid systems. But here's a little secret. Most of your complex catheter coding is going to happen right there on the arterial side. Let's break down that arterial family a bit more. We'll work logically, starting from the top of the body all the way down to the toes. First up, we have the intracranial arteries, located inside the skull, supplying the brain. Moving down into the neck, we've got the carotid arteries, which supply oxygen-rich blood to the face and head. Drop down into the chest, and the coronary arteries are there supplying the heart muscle itself. Then in the abdomen, the visceral arteries branch off the aorta to feed internal organs, like your liver and spleen. And finally, the lower extremity arteries carry blood down to the legs, and this includes the iliac, femoral, and tibial arteries. You can think of each of these distinct regions as its own unique neighborhood.
And when you consider there are over 60,000 miles of blood vessels in the human body, yeah, knowing your neighborhoods is absolutely critical. Section 4. Selectivity and the final placement rule.
So the crucial point here is understanding exactly how to code a catheter as it actually travels through these neighborhoods we just talked about. Let's dive right into those core coding rules. But wait, before we place the catheter, we must know its purpose, right? Diagnostic catheterization focuses purely on imaging. The physician injects contrast dye to light up and visualize the blood vessels, perform an angiography, and basically identify any diseases. Therapeutic catheterization goes a step further. Here, the physician is actively treating or managing a condition using that catheter, maybe by performing an angioplasty to open up a blocked vessel or by placing a stent. Regardless of whether it's diagnostic or therapeutic, this brings us right to golden rule number 1. You must always consider the end point of the catheter. The final resting place of that catheter tip determines your placement code. Let's say the catheter travels through a main artery, takes a first-order branch, and then parks itself in a more distant second-order branch, all within the same family. In that scenario, you only code that final second-order branch. All those lesser intermediate selections and non-selective steps the physician took along the way, they are inherently bundled into that single highest-level code.
Section 5. Practical coder tip. Let's make this concrete with a practical example so you can see how this builds into your daily workflow. Honestly, applying these rules correctly is exactly what separates novice coders from the true experts. Imagine you're reading this operative report. The patient is in the angio suite. The physician accesses the right femoral artery. That's step 1. They advance the guide wire and catheter up into the abdominal aorta. Step 2. Then they cross over the aortic bifurcation, advancing the catheter down into the left common iliac artery. Step 3. Finally, they advance the catheter even further down the leg, parking it in the left superficial femoral artery to evaluate the tibial level. That is step 4, the final resting place. Now, if you try to code the aorta and the common iliac and the superficial femoral artery, you are going to get hit with a massive unbundling denial. That brings us to golden rule 2. Always code the most selective placement. You only report the highest branch order reached within that single vascular pathway. The intermediate stepping stones are bundled. But what if you branch out? Golden Rule 3 states that if your catheterization reaches the same order in 2 distinct vascular families, you report 2 primary codes and append Modify 59 or excess to flag the separate anatomy. And Golden Rule 4, if you catheterize 2 different orders within the same family, you report 1 primary code for the furthest, most distal point, and then you use an appropriate add-on code for the extra branches explored in that family. Mastering these 4 rules is exactly what ensures your claims sail smoothly through payer audits.
Section 6. Summary and next time.
We've covered some incredibly vital ground today. To quickly recap, we defined interventional radiology and separated vascular from non-vascular procedures. We explored the distinct arterial vascular families, from intracranial all the way down to the lower extremities. But most importantly, we locked in those 4 golden rules, focusing heavily on how the endpoint of the catheter dictates your code and how modifiers handle branching paths. These 4 foundational rules are honestly your best defense against coding denials. Think about it. If a single catheter placement can bundle so many intermediate steps, how much revenue is your practice losing if you aren't using modifiers 59 or excess correctly? Next time, in Part 12, we're going to tackle a fascinating topic. What exactly is abdominal runoff, and how do we code diagnostic aortography alongside extremity imaging? You definitely won't want to miss it. Thank you for watching, and keep learning with Decode Healthcare with Hershal.